How do I manage a patient with heart failure, liver disease, ascites, HIV on ART? This is a very challenging case that is increasingly common in our clinical scenario where people survive longer with HIV. And this requires multidisciplinary care to manage such a patient. This is not a single organ system. Multiple organs are involved, and managing the patient safely requires balance, vigilance, and teamwork. The multi-system condition requires multidisciplinary care. This patient likely has a combination of cardiac cirrhosis or congestive hepatopathy or primary liver disease, whether viral, drug-related, metabolic, plus HIV on ART, which adds drug-to-drug interactions. So first, understand the cause of the ascites because treatment is different. Not all ascites is not due to liver causes. In heart failure, especially right-sided heart failure, the liver becomes congested, leading to what we call cardiac ascites or congestive hepatopathy. Why does this matter? Because cardiac ascites responds very well to diuretics, while advanced liver disease may not. So some of the clues that point to cardiac causes may include raised GIVP, orthopnea, PND, tender hepatomegaly. If the patient has a splenomegaly and low platelets, this may indicate the liver as the primary cause of the ascites, what we call portal hypertension. You also need to do your SAG, serum ascites albumin gradient. If you have a high SAG plus a high protein, this means cardiac ascites. High SAG and low protein, liver cirrhosis. So often both may be in the same patient, heart and liver contributing, and we must treat both together. The second part is diuretics. Diuretics are cornerstone to treatment. Use them, but use them wisely. So in the ascites in this setting, spironolactone, aldactone is the backbone. Low-dose diuretics such as furosemide can be added, and a common ratio is 100:40 of spironolactone to furosemide. But caution is critical. Liver disease increases the risk of high potassium, hyperkalemia, and heart failure increases the risk of kidney injury. So caution is required. So you need to do frequent monitoring of the electrolytes, daily weight checks, watching the blood pressure closely. Number 3, adjust the standard heart failure drugs carefully. Medications like ACE inhibitors, ARBs, ANIs can still be used, but only if the blood pressure and kidney function allow. In advanced liver disease or hypertension, these drugs may need to be reduced or withheld. Remember, BP below 90/60, you may need to hold those drugs. Beta blockers are important, but you start slowly and increase gradually. The beta blockers we use in heart failure. Aggressive dosing should be avoided. Remember, non-selective beta blockers, e.g. propranolol, used for portal hypertension can worsen heart failure, so they should not be used in this setup. MRAs, spironolactone, we have discussed above, is very useful, but monitor your potassium. What about SGLT2 inhibitors? These are generally safe and have minimal hepatic metabolism, but watch the volume status. The key point number 4 is ascites-specific measures save lives. Salt restriction is key in these patients with ascites. If they have hyponatremia, they also need fluid restriction. For tense ascites, you obviously need therapeutic paracentesis. Large volume taps should always be accompanied with albumin, with your IV albumin, and always assess for confusion, drowsiness, rising creatinine, hyponatremia. These may be signs of worsening decompensation. The 5th is ART and drug-to-drug interactions, which is also a hidden danger in this patient. Antiretroviral therapy is life-saving, but some of the protease inhibitors interact with heart failure medications. They can increase levels of beta blockers, digoxin, amiodarone, and certain statins. So you should not use simvastatin, but low-dose atorvastatin, rosuvastatin are safer options. For the ART, drugs like the DTG is preferred because it has less drug-to-drug interactions. And finally, think teamwork, not solo. Multidisciplinary care is important in such a patient. Refer to a higher level facility so that the patient can be managed by a multidisciplinary team, which includes cardiology, hepatology or internal medicine, and the HIV care team. The goals are simple but delicate. Relieve congestion, protect the kidneys, avoid dangerous drug-to-drug interactions, maintain viral suppression as you improve quality of life for the heart failure and reduce mortality and morbidity. And finally, when heart failure, liver disease, and HIV interact, it is not one size fits all. You need multidisciplinary care, and these patients can be stabilized, supported, and live well. But management should be in a high-level facility with all the relevant specialists. This is Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.